So what's the most sensitive test for detecting recurrence? So remember, it's like diagnosing Cushing syndrome only. And I'm asking what is the most sensitive test for diagnosing Cushing syndrome? Because in a case of a prior Cushing's disease, that is already the adenoma has been there. If you want to detect recurrence, you wanted the most sensitive test. That's the reason I'm going to go for the most sensitive test. You have three options. The one that we don't use commonly, that is 24-hour urinary free cortisol. You have some URL, that is upper reference limit given by your lab. And if the values are limited by more than 2 to 3 times the upper reference limit, you can probably make a diagnosis of Cushing syndrome, in this case recurrent Cushing's disease. But this is not really recommended because this is not a very good test because it's not having that much sensitivity and specificity. But nevertheless, if the values are increased by more than 2 to 3 times the upper limit of normal, I can say probably yes, this patient is having recurrent Cushing's disease. And second, you can use something called low-dose dexamethasone suppression test, or any dexamethasone suppression test is fine. Why you're going to use dexamethasone? Because you're going to test serum cortisol at the end of the test. So your steroid should not interfere with cortisol testing. So that's the reason why you're going to use synthetic steroids like dexamethasone, which doesn't interfere with the cortisol assays. That's the reason why you use dexamethasone. Dexamethasone is a very, very powerful glucocorticoid. It suppresses the entire HPA axis. And in low-dose dexamethasone suppression is the conventional one. We're going to give 0.5 milligram dexamethasone 6th hourly for 48 hours, which means 8 doses of dexamethasone, 2 days you have to give. The next day morning, you test serum cortisol. And if the serum cortisol values are more than 50, I can confirm it's a Cushing's syndrome, because you're trying to suppress the HPA axis. But if it is not suppressible, you can prove that it is working too much. It's excess. It's a kind of a suppression test that doesn't work. So that's why you're proving excess over here. So that's the principle behind low-dose dexamethasone suppression test. Because the conventional testing involves 8 doses over 2 days, patients may not be compliant for this, right? So that's why we have an alternative in the form of something called as overnight dexamethasone suppression test. This is an alternative to LDST. In overnight dexamethasone suppression test, you are going to give just 1 dose of dexamethasone, approximately 1 milligram, the previous night by around 11 p.m. And the next day morning at 7 to 8 a.m., we are going to test serum cortisol. If the values are more than 50, still we can make a diagnosis of Cushing syndrome, right? And the diagnostic accuracy of ODST is almost comparable with LDST, so it's not a problem. In modern practice, we tend to go for ODST than LDST. But whatever may be the test, always make sure cortisol testing should be done as outpatient. Why? Because inpatients by default will be under stress, so cortisol levels will be high in inpatients, and it's better not to do cortisol testing as an inpatient unless until you have any other strong indication to do it. So always do cortisol testing as an outpatient. Otherwise, you will end up with a diagnosis of pseudo-Cushing's, because pseudo-Cushing means physiologic hypercortisolism. The most common cause of pseudo-Cushing is stress. And last but not the least, we have another test called as late night salivary cortisol. I'm not using any suppression test here, but I'm using the diurnal variation of cortisol. So with that, I'm going to test something called late night salivary cortisol. We're going to give a test tube to the patient and ask them to spit the saliva by around 11 p.m. to 12 a.m. in the night. And why we are doing that? Because at night or at around 11 p.m. to 12 a.m., your cortisol and STH levels has to be at rock bottom. It should be very low. But if it's very high, you're proving loss of diurnal variation. In endocrine disorder, one of the first things to happen is loss of diurnal variation. At a time where the cortisol levels are supposed to be very low, if you prove if the values are very high. In my lab, if the values are more than 5, it is diagnostic. So the values are very high at night, I can say it's loss of diurnal variation, it is Cushing's syndrome. And in this case, I can diagnose Cushing's disease, and this is the most sensitive test. Technically speaking, for diagnosis of Cushing syndrome, this is the most sensitive test. And this is the test I want to make a diagnosis of recurrent Cushing's disease like a patient of mine. Right, so late night salivary cortisol is the most sensitive test for diagnosing Cushing syndrome as well as for recurrence of Cushing syndrome, like in this case. And remember, cortisol and STH have diurnal variation. As I said, 11 p.m. to 12 a.m., they're going to be very low. In the morning, 7 a.m. to 8 a.m., they're going to be very high. And next to go for imaging, right? So the standard rule in endocrine testing is first always confirm biochemically, and hormonal testing is a must to begin with. And then only, if you prove in the hormonal testing, then you do MRI or whatever imaging you want to do. Because if you do imaging first, you might falsely pick up some incidentalomas and you can confuse with that. So that's why you don't want to do that. And we want to always first do hormonal testing, then go for imaging. So in this case, MRI was repeated because our primary suspicion was regrowth of pituitary adenoma. MRI of the pituitary did not show clear recurrence. You can see this was the previous MRI a couple of years ago, and this is the current MRI. You don't see that much of a difference, right? But hormonally, you are very clear that the patient is having Cushing's syndrome. Right. So what is the gold standard for suspected diagnosis? So here the diagnosis that suspected is regrowth of pituitary adenoma or recurrent Cushing's disease. So for this, the gold standard is going to be bilateral IPSS. If they ask about pituitary adenoma and if they ask about gold standard, it's going to be bilateral IPSS, that is inferior petrosal sinus sampling. That's it. There's no doubt about that. Inferior petrosal sinus sampling. So what you're going to do, you're going to cannulate both the petrosal sinuses and you're going to take samples out of it and you're going to send for ACTH analysis. And you're going to take a systemic sample and again send for ACTH analysis and you're going to compare the IPSS ACTH versus the systemic ACTH. If it's going to be pituitary adenoma causing Cushing syndrome, the IPSS ACTH must be way more compared to the systemic ACTH, and if the ratio is more than 2, or with CRH stimulation, the ratio is more than 3. This literally confirms that you're dealing with Cushing's disease, that is pituitary adenoma or corticotroph adenoma causing Cushing syndrome, right? If the IPSS ACTH versus systemic ACTH is more than 2, or with CRH stimulation, if it's more than 3, it is Cushing's disease unless proved otherwise. And this is the gold standard for diagnosing Cushing's disease as a whole.